Hi, I'm Dr. Kathy Albane, and welcome to Key Insights. I'm Professor of Medicine at Loyola University Chicago Stritch School of Medicine, where I direct the Breast Clinical Research Program. I am pleased to bring you Key Insights from the 13th Annual The Best of San Antonio Breast Cancer Bench to Bedside, held in downtown Chicago in early February of 2016. With this being our 13th annual meeting, we've built on the successes of previous meetings by again bringing in outstanding, nationally known faculty who provide not just an abstract by abstract review. We go beyond that and we pick key topics that are either controversial, new, exciting, and give a critique in addition to reporting on the new data presented at the December 2015 San Antonio Breast Cancer Symposium. So this year, we had 7 faculty for this half-day symposium. In addition to myself, they included Dr. Suzanne Fuqua from Baylor College of Medicine in Houston, Texas, Dr. Shelly Lowe from Loyola University Chicago Stritch School of Medicine, Dr. Jay Harris from the Dana-Farber Cancer Institute and Harvard Medical School in Boston, Dr. Matthew Ellis from Baylor College of Medicine in Houston, Dr. Lajos Pusztai from Yale University and Yale Cancer Center in New Haven, Connecticut, and Dr. Hal Burstein from the Dana-Farber Cancer Institute in Boston. In the audio portion of Key Insights, to follow my introduction, you will be hearing me discuss various topics that were highlighted by our speakers. There was a lot of crosstalk at our meeting, meaning several speakers might address a single paper or a series of papers from different angles. So I will highlight that for you in a way that brings you up to date with the most exciting components and the most controversial components of the meeting.
Our first speaker was Dr. Shelly Lowe, who addressed updates in prevention and survivorship presented at the recent San Antonio meeting in December of 2015. She began by discussing genetic risk prediction beyond BRCA1 and 2. She highlighted the Tuesday, December 8th San Antonio educational sessions presented by Dr. Susan Doncheck and Mark Robson. They addressed multi-gene panel testing for moderate penetrance genes, testing now recommended for most patients, in terms of clinical validity and actionability in practice, as well as variants of uncertain significance. Of particular interest were data on how the presence of various moderate penetrance genes may be useful in determining at what age to begin breast MRI and other screening tools. I encourage you to watch the full presentations of these 2 experts on the sabcs.org website, as well as additional poster discussion presentations also available online. Dr. Lowe next considered the first report of the IBIS-2 Adjuvant DCIS trial presented at the San Antonio Breast Cancer Symposium by Dr. Jack Kuzik and colleagues. This was a phase 3 randomized trial of tamoxifen versus anastrozole in 2,980 postmenopausal women with ER-positive DCIS. While there were numerically fewer invasive and DCIS events with anastrozole, this was not statistically significant. When placed in context with the NSABP B35 trial of similar design, which did find a statistically significant advantage to anastrozole, as well as the decrease in breast events on the ATAC trial, the collective data meta-analysis also reviewed at San Antonio meeting favors anastrozole. To date, no overall survival advantage has been reported, but follow-up is ongoing in both the IBIS-2 and NSABP B35 trials. In the IBIS-2 trial report at San Antonio, there was no overall effect on other cancers, with the expected decrease in rates of uterine, ovarian, and even skin cancers in the anastrozole arm compared with tamoxifen. Dr. Patricia Ganz's presentation of the patient-reported outcome, or PRO, results from the Energy Oncology NSABP B35 trial in ER-positive DCIS was highlighted as an important contribution to risk-benefit analysis of endocrine therapy for DCIS. Dr. Lowe reviewed that the PRO data showed both anastrozole and tamoxifen are well tolerated, with greater severity of some symptoms in women under the age of 60. the symptom profiles differ in the expected direction for these common agents. These important data now allow the clinician to use these results to tailor choice of possible adjuvant therapy in the DCIS setting on a case-by-case basis. The last section of Dr. Lowe's review focused on 3 other survivorship issues of interest at the San Antonio meeting. In a poster presentation, Dr. Carter and colleagues presented encouraging data on a non-hormonal application of hyaluronic vaginal gel, which significantly improved vaginal complaints and other sexual health concerns in breast cancer survivors. An important study from Dr. Carolyn Taylor on behalf of the Early Breast Cancer Trialist Collaborative Group in Oxford demonstrated the late effects of modern breast radiotherapy doses to the heart and lungs, adjusting for smoking status at the time of breast radiotherapy. Active smokers had a much greater rate of lung cancer if they received radiation than those who did not get radiation. But in non-smokers, there was no difference in lung cancer rates by radiation status. However, there was no difference in rates of ischemic heart disease if radiation was given or not among smokers or non-smokers. So smoking status can determine the net long-term effect of breast radiotherapy on mortality. Smoking cessation at the time of radiotherapy may avoid most of the risk in these patients. The paper of Dr. Petuskin and colleagues, the Manticore 101 study, addressed the safety and tolerance of ACE inhibitors and beta blockers in patients receiving 17 cycles of trastuzumab, as measured by change in left ventricular function on the cardiac MRI. In some, prophylactic beta blockade preserved LVEF, and ACE inhibitors did as well, but not to the same degree. Dr. Lowe reviewed a similar study, the PRADA study, recently presented at the American Heart Association meeting this last year. This patient population received either anthracyclines or trastuzumab, and the investigators reported that angiotensin II receptor blockers were effective, but beta blockers were not. These 2 cardio-oncology trial results, if validated in larger trials, hold promise for reducing the risk of cardiac dysfunction in patients receiving trastuzumab and possibly anthracycline. The next faculty presenter was Dr. Suzanne Fuqua, who discussed high-impact translational research presented at the San Antonio meeting in December of 2015. A dominant translational research theme this year, including at the San Antonio meeting, was ESR1 mutations. I call your attention to the online first release of Drs. Gu and Fuqua's outstanding editorial entitled ESR1 Mutations in Breast Cancer, Proof of Concept Challenges Clinical Action in Clinical Cancer Research, now available online and to be published March 1st, 2016. During her presentation, Dr. Fuqua highlighted much of what is contained in her editorial as she reviewed the San Antonio abstracts pertaining to ESR1 mutations. In particular, correlating mutations with outcomes in the Bolero-2 and Fergie trials. ESR1 ligand-binding domain mutations are in the agonist conformation. Thus, they confer hormone independence, and their presence often portends resistance to aromatase inhibitors. They are frequently present in aromatase inhibitor-resistant ER-positive metastatic breast cancer in about 40 to 50% of cases. In the past, they were thought to be rare in primary tumors, but new techniques, in particular digital droplet PCR, can find these mutations in almost 10% of primary tumors. Furthermore, the use of liquid biopsies of cell-free DNA and/or circulating tumor cells greatly improves the impact of mutation analysis over time on clinical trials, which previously had been restricted to the often difficult approach of serial tumor biopsy. Not all ESR1 mutations have the same response, however, as demonstrated in the San Antonio Breast Cancer Symposium report. For example, the Y537S may not respond to everolimus, but the D538G may respond, as shown in the Bolero-2 trial report of exploratory prognostic and predictive analyses using the cell-free DNA approach. Certain mutations were predictive of more aggressive biology and shorter survival. We are waiting data on ESR1 mutations in the context of treatment with CDK4/6 inhibitors, but the San Antonio report from the Fergie trial of fulvestrant, with or without the PI3 kinase inhibitor pictolisib, was a step forward. The results imply that ESR1 mutations may confer more sensitivity to selective estrogen receptor downregulators, or SERDs, such as fulvestrant. As of yet, none of these findings are clinically actionable and should not be used outside of a clinical trial. However, they hold great promise, as Dr. Fuqua stated, that the recent work of Nicholas Turner et al. And others showed evolution of mutations over time. It is probable that ESR1 mutations may be drivers of metastasis and that ongoing therapy may drive the evolution of mutations. Using serial liquid biopsies to analyze for this mutational evolution in residual or micrometastatic disease before relapse may become useful in the near future to monitor treatment response as well as identify new therapeutic targets in advanced disease settings. Dr. Fuqua reviewed the San Antonio presentation of Dr. Fabrice André as presented in Mini Symposium 2 on targeted therapy and precision medicine. You are encouraged to review this on the sadcs.org website because according to Dr. André's overview, the current research demonstrates that there is no evidence for a better patient outcome when the therapy is determined based on a large panel of genes versus best physician choice. Dr. Fuqua reviewed the reasons for this disappointing outcome and told the audience to look for a pending publication on the MAP or MAP consensus in the Annals of Oncology. Other presentations of major import were reviewed by Dr. Fuqua, as she concluded, and of specific interest were those of Dr. Pascal Gellert on mutational profiles on paired primary tumor and metastases during aromatase inhibitor therapy, and Dr. Marnie Siegel on early versus late genomic drivers of metastasis using serial results, including autopsy. Dr. Siegel and colleagues showed that phylogenetic trees could be developed from each patient, demonstrating that metastasis results from multiclonal seeding from the primary, and that clones favor some organ sites over others. This adds so much more challenge to our treatment of what is a very heterogeneous disease, not just among patients, but within each patient, and over time within each patient. Dr. Jay Harris provided the next faculty presentation on perspectives in local regional control. He first addressed the often changing issue of proper margin width and re-excision by reviewing the Danish Breast Cancer Group study of Dr. Anne Bodesen and colleagues. This was a population-based study in 11,900 patients treated for invasive breast cancer with breast-conserving therapy. Increased ipsilateral breast tumor recurrence risk was associated with a positive margin, but was similar for any negative margins regardless of width of margin. Also, there was increased ipsilateral breast tumor recurrence with residual disease present on the re-excision even if the eventual margin was clear. This is a novel finding and is hypothesis generating and could be looked at in other studies. Dr. Harris's commentary underscored that these results overall were similar to the SSO-ASTRO consensus on margins, and did note that in the United States, no ink on tumor defines a negative margin, whereas in European studies, it must be at least 1 millimeter from the ink. Next, Dr. Harris reviewed another population study, this one from the Netherlands Cancer Registry of 37,000 patients, as presented in San Antonio by Dr. Van Maren. The researchers addressed the 10-year survival of patients treated by physician choice with either mastectomy or breast-conserving therapy. Utilizing multivariate modeling, there was a 19% reduction in deaths in the breast conservation therapy cohort, which was true in all T and N subsets. Dr. Harris provided commentary on these findings that they are provocative, but retrospective and not level 1 evidence. However, he reviewed recent data that local recurrence rates for breast conservation therapy are now less than or equal to mastectomy, and despite this, we are seeing more patients electing mastectomy, often bilateral. Dr. Harris highlighted the comments pertaining to this issue in Dr. Norman Woolmark's McGuire address, which can be viewed on the San Antonio Breast Cancer Symposium website. As women without a known genetic risk are contemplating bilateral mastectomies at an escalating rate, these new data give one pause and should be raised with our patients in the clinical setting. Dr. Harris followed with a review of an interesting paper on the complications and economic burden of local therapy options for early breast cancer, a paper given at San Antonio by Dr. Benjamin Smith and colleagues. Not surprisingly, mastectomy and reconstruction was both more costly and had a twofold higher complication rate than breast conservation therapy with radiotherapy, though the use of brachytherapy in the breast conservation therapy group modestly elevated complication rates. Dr. Harris stated in his commentary on this abstract that, quote, "I wonder whether patients or payers will ever realistically consider the costs of their options, although they might be swayed by the risk of complications," close quote. The final portion of Dr. Harris's presentation was an excellent synthesis of the 3 San Antonio presentations by Drs. Reshma Jagsi, Terry Mamunos, and Tim Whalen, along with Dr. Harris's own plenary address on the status of who should get axillary nodal radiation. This is a controversial issue, and no clear consensus exists among experts. The question addressed in depth by Dr. Harris was, how does one reconcile the results of the Z11 and MA20 trials? His concluding commentary provided his perspective on how he approaches each patient in his practice regarding whether to give nodal radiation. He uses the MD Anderson nomogram to estimate the probability of positive non-sentinel nodes. If this is low, that is less than or equal to 25 to 30%, a la the Z11 trial eligibility, he would use high tangents only. If the probability of positive non-sentinel nodes is high, a la MA20 trial, he then adds nodal fields, also factoring in comorbidities and age. If you are interested in more details on this topic, you are encouraged to watch Dr. Harris's full address at the plenary session of the San Antonio Symposium on December 9, 2015 on the website, as well as the Clinical Science Forum on this topic presented later that same day on sanantoniobreastcancersymposium.org. Our 4th faculty member was Dr. Matthew Ellis, who brought his perspective on new directions in novel therapeutics for advanced and early disease. Dr. Ellis started out by posing 5 questions. 1. How will documentation of complex somatic mutation patterns help breast cancer clinical care? 2. Is circulating tumor DNA analysis clinically valuable? 3. Is anti-tumoral immunity activated by chemotherapy? 4. Could new insights into the metastatic process translate into new therapeutic interventions? And 5. Is mass spectrometry-based proteomics the next step in our tumor omics analysis? These questions were addressed by an elegant discussion of translational research results in the recent literature and at the San Antonio meeting. I will now highlight a few of them as discussed by Dr. Ellis. He first considered that breast cancer genomic evolution is chaotic. In other words, there is no fixed temporal order. Multifocal disease is clonally related, but can exhibit clonal sweep, with dominant mutations in one focus and another set in another focus. Post-neoadjuvant chemotherapy samples can exhibit new driver mutations. In other words, a single look for a therapeutic driver makes little sense. We need continuous genomic monitoring, which builds on the points made by Dr. Fuqua earlier. In Dr. Ellis's words, quote, "Precision medicine driven by DNA sequencing of a single pretreatment sample is a naive proposition," close quote. Failure of PI3 kinase inhibition may be due to rapid acquisition of PTEN mutations, but there were some encouraging results presented by Dr. Baselga on behalf of the BEL-2 trial investigators that Dr. Ellis reviewed for us next. This was a large randomized trial of fulvestrant plus minus buparlisib among postmenopausal women whose disease had progressed on an aromatase inhibitor. Overall, the results demonstrated a very modest but statistically significant 2-month prolongation of progression-free survival. The encouraging translational research findings presented at San Antonio by Dr. Baselga were that while the PIK3CA status in the primary tumor biopsy did not predict benefit of the inhibitor, there was a very clinically meaningful improvement in progression-free survival among patients whose circulating tumor DNA had PIK3CA mutations. Dr. Ellis provided a complementary discussion of techniques for the detection of circulating tumor nucleic acids, complementing the review of Dr. Fuqua earlier. These techniques include digital droplet PCR, which is targeted, next-generation sequencing, which is untargeted, sequencing of circulating tumor cells, extracellular RNAs, and circulating microRNA analyses. Dr. Ellis also highlighted the recent work of Dr. Nicholas Turner and colleagues, which showed that when cell-free DNA from the tumor appears in the circulation, a clinical relapse will occur in approximately 12 months from that time, and that if no circulating tumor DNA appears, there is no relapse. The burning question, of course, is will treatment of this quote-unquote molecular relapse result in an overall survival improvement? Does early intervention after detection of circulating tumor DNA improve outcomes? And could salvage therapy be more effective if started at the time of the molecular relapse? We do not yet know the answers to these questions. Dr. Ellis expanded on the comments of Dr. Fuqua regarding ESR1 mutations, taking into account multiple San Antonio presentations and recent publications. ESR1 mutations can be accurately assessed in the plasma from patients with advanced disease and appear to be particularly associated with aromatase inhibitor therapy rather than selective estrogen receptor downregulators, or SERDs, and SERMs. They predict poor outcomes from treatment with aromatase inhibition, but are they clinically actionable? We are not quite there yet, said Dr. Ellis, but we will be soon. ESR1 mutations may be particularly targetable with new class of SERD-SERM hybrids combined with CDK4/6 inhibition, but work is still in progress. However, Dr. Ellis suggests that ESR1 mutation status is ready for prime time as a stratification or eligibility factor in clinical trials conducted in endocrine-resistant disease. Regarding breast cancer tumor immunology, Dr. Ellis discussed his own San Antonio presentation. The chemotherapy acts like a vaccine with neoantigens released, resulting in anti-tumor immunity with chemoattractants, including annexin-1, for dendritic cells, which in turn present tumor antigens to T cells. Dr. Ellis proposed that we should consider redesigning our chemotherapy regimens to maximize this tumor vaccination effect. He then reviewed the presentation of Dr. Hope Rugo and colleagues on the breast cancer cohort within the large Keynote 028 trial of pembrolizumab in patients with PD-L1 positive, ER positive, HER2 negative metastatic breast cancer. The response rate was 12%. In prior reports, the response rate in triple-negative breast cancer was about 20%. Thus, there appear to be subsets of patients with breast cancer who may benefit from immunotherapy, and results are ongoing in clinical trials in both advanced and early breast cancer, which are awaited with great interest. I took the podium next to discuss the San Antonio Breast Cancer Symposium 2015 advances from adjuvant and neoadjuvant breast cancer studies. The first half of my presentation dealt with 4 themes of adjuvant therapy that dominated the meeting: less and more, long-term survival updates in phase 3 trials in HER2-positive disease, targeting bone to improve survival, and treatment after neoadjuvant disease when there is residual disease in the surgical specimen. So first, the theme of less and more, adjuvant therapy. One of the highlights of 2015 was the New England Journal of Medicine publication of Dr. Joe Sperano and colleagues of the first report from the TAILOR-X trial in patients with node-negative, ER-positive, HER2-negative breast cancer with a 21-gene recurrence score, or oncotype score, of less than 11, who were treated with endocrine therapy alone. Invasive disease-free survival, distant disease-free survival, relapse-free survival, and overall survival were all at or well above 95% at 5 years, indicating these patients with higher risk node-negative disease who were enrolled on the trial can be spared chemotherapy. 2 San Antonio Breast Cancer Symposium abstracts on large databases provide supportive evidence to the findings in the TAILOR-X trial. The first was Israel's Clalit Healthcare System database report. In this healthcare system, there is mandatory use of the recurrence score, and the physicians are required to use its results to guide therapy as to whether to avoid chemotherapy or to give chemotherapy. The second study was a SEER-based analysis where the recurrence score and the treatment rendered were both known. These results from these two databases were presented at San Antonio by Dr. Stemmer and colleagues and Dr. Shack and colleagues, respectively, from the Claylet and SEER analyses. The bottom line in both of these reports was that avoiding chemotherapy for recurrence scores that were low had outstanding outcomes, as did using chemotherapy in the high-risk patients with high recurrence score. While we have increased confidence to avoid chemotherapy in these subsets of ER-positive node-negative disease, we have also seen recent prospective trial evidence that treating small node-negative HER2-positive tumors with trastuzumab plus paclitaxel yielded outstanding outcomes. This was the APT trial published in the New England Journal of Medicine by Dr. Sarah Tolaney et al. At the San Antonio meeting, Dr. Van Ramshorst and colleagues from the Netherlands presented a population-based analysis on the effect of trastuzumab-based therapy on overall survival in small, node-negative, HER2-positive breast cancer. Breast cancer-specific survival was 100%, 99%, and 96% in T1A, T1D, and T1C disease, respectively, at 8 years, if trastuzumab-based therapy was given. Thus, highly concordant with the report of Tolaney et al. In the New England Journal of Medicine. The main area where we do not yet have confidence in whether to give more or less treatment on an individual patient level, in terms of duration at least, is in the ER-positive HER2-negative population. Many previous reports have described a constant low late event rate of about 0.5 to 1.0% per year, which results in a not insignificant lifetime cumulative risk of developing events of 10 to 12%. Newer molecular profiling tools define who may be at risk for late events. These include Oncotype DX, EndoPredict, PAM50-ROR, BCI, and circulating markers. Unfortunately, we know very little about what is the best predictor for success of a specific treatment approach to eradicate the late events completely that is tailored to the specific mechanism or mechanisms of late events operative in a given patient. Longer endocrine therapy will help some patients, but not all, because of multiple competing mechanisms of resistance, including crosstalk and upregulation of compensatory pathways such as HER2, mTOR-AKT, CDKs, and IGFR, alteration in coactivator and co-repressor protein, mutations in ESR1, as we have already discussed today, and resistance of the breast cancer stem cell to standard treatment via the Notch pathway. At San Antonio, I presented new data on predictors of relapse and chemotherapy benefit in the node-positive, ER-positive postmenopausal population enrolled on SWOG 8814, treated with tamoxifen or chemotherapy with CAF followed by tamoxifen. We previously demonstrated that among those with a low 21-gene recurrence score tumor, there was no improvement in disease-free survival, breast cancer-specific survival, or overall survival over 10 years by the addition of chemotherapy to 5 years of tamoxifen. The new data we just presented at San Antonio was a next-generation sequencing analysis of over 20,000 genes using the RNA we stored from the previous recurrence score analysis. Many genes were prognostic for disease-free survival events in the first 5 years, but only a few genes in the second 5 years. However, using Cytoscape, we could address networks of genes. Genes prognostic for worse disease-free survival in the tamoxifen arm were enriched for proliferation, DNA repair, epithelial mesenchymal transition, or EMT, cellular metabolism, and stress response, metagene. Of note, the low ESR1 metagene signature was associated with early recurrence, but the high proliferation gene network impacted both early and late events. So using a 5-metagene model adjusted for nodes, a group with excellent long-term outcome over 10 years could be identified among patients who received tamoxifen alone, despite positive axillary lymph nodes. The second adjuvant therapy theme that I addressed pertained to long-term survival updates of 3 adjuvant phase 3 trials conducted in HER2-positive disease. The first important update was presented by Dr. Dennis Slayman for the BCIRG 006 investigators. In prior updates, both trastuzumab-containing arms, that is AC followed by TH, and TCH were superior for disease-free survival and overall survival versus AC followed by T with no trastuzumab. But there was a numerical superiority of ACTH over TCH that has always engendered debate about the wisdom of omitting anthracyclines in HER2-positive adjuvant breast cancer therapy. In this new update of 10-year outcomes, the benefit to TCH versus AC followed by T remained robust, and while still numerically inferior to AC followed by TH, the difference between the two Herceptin-containing arms was not significant. So the 10-year results were 74.6%, 73%, and 69% respectively for ACTH, TCH, and ACT. As reported previously, the toxicity profile favored TCH with less leukemia and cardiac events. Survival outcomes by treatment arm were similar in higher risk subsets, for example, 4 or more positive nodes. But this trial was not powered to be certain if the numerical difference favoring ACTH versus TCH would be significant in the many positive node group if a large trial was conducted in that group alone. Thus, some clinicians still consider ACTH to be favored for the highest risk subgroups. However, the new data were very reassuring at long-term follow-up for TCH in general. And one other question is still being raised, with cures evident in the majority of patients in the non-trastuzumab arm. As I just stated, the 10-year outcome was 69% in that group that did not receive trastuzumab. So who are these patients with HER2-positive disease who do not need trastuzumab? We do not know at the present time. The second update in HER2-positive disease presented at San Antonio was the 10-year outcomes in the HERA trial for 1 versus 2 years of trastuzumab after completion of adjuvant chemotherapy versus no trastuzumab. The two major findings from the prior reports on this study have held up at this 10-year analysis. The control arm still had inferior survival, and 2 years of trastuzumab was not better than 1 year. An interesting new analysis by hormone receptor status showed that the pattern of relapse was different. Relapses occur early in the ER-negative HER2-positive cohort, with a plateau occurring after several years, versus there are steady rates of still continuing relapse out to 10 years in the triple-positive or HER2-positive ER-positive cohort. The third HER2-positive adjuvant trial update was the ExteNet trial presented by Dr. Arlene Chan and colleagues. The 2-year outcomes were presented last year and are now published in Lancet Oncology. The San Antonio 2015 update was an exploratory 3-year analysis of this trial. This trial was designed to address the greatest period of relapse in HER2-positive disease, which is the year after completing adjuvant trastuzumab. So patients at 1 year or less after receiving their last standard trastuzumab were randomized to the pan-HER agent neratinib versus placebo for 1 year. The 2-year invasive disease-free survival was superior in the neratinib arm overall. Severe diarrhea occurred in this trial, which did not employ prophylactic antidiarrheal therapy. In a recently reported webcast of a new study conducted by PUMA, the diarrhea event rate from neratinib is significantly lowered by prophylactic antidiarrheal therapy. In this new update of the ExteNet trial at San Antonio, the 3-year exploratory invasive disease-free survival continued to strongly favor neratinib, but only in the ER-positive cohort, again supporting the different recurrence trajectory over time in HER2-positive disease for ER-positive versus ER-negative cohorts. The third adjuvant theme at San Antonio involved targeting bone to improve survival in the adjuvant setting. The Early Breast Cancer Trialist Collaborative Group reported the adjuvant bisphosphonate overview in the Lancet in 2015. There was a 14% relative reduction in recurrence, which was an absolute difference of 3%. At ASCO 2015, and as published last year in the Lancet, Dr. Michael Ganant and colleagues of the ABCSG 18 trial reported a significant reduction in time to fractures and other skeletal events using adjuvant denosumab 60 milligrams twice yearly for 3 years in postmenopausal women being treated on adjuvant aromatase inhibitors. At San Antonio 2015, The first disease-free survival results from this trial were presented by Dr. Ganz with an 18.4% reduction in events, which is a 3% absolute improvement by denosumab with a p-value of 0.05. So the evidence is mounting in favor of targeting the bone in the adjuvant setting, and it is hoped approval will soon follow for insurance coverage in women who do not receive these agents already for decreased bone density. The fourth theme that I reviewed in the adjuvant setting was treatment after neoadjuvant therapy if there is residual disease present at surgery. This topic is of great clinical interest given the common clinical dilemma in patients with positive nodes or residual tumor in the breast after completion of neoadjuvant therapy. A joint Korean-Japanese trial was presented at San Antonio in 900 such patients. They were randomized after neoadjuvant chemotherapy followed by surgery to receive capecitabine at 2,500 milligrams per meter squared per day, 2 weeks on, 1 week off, for 6 cycles, later amended after a safety analysis to 8 cycles total. However, completion rate for 8 cycles was only 38%, and 36% had grade 2 to 3 hand-foot syndrome. Nevertheless, marked disease-free and overall survival benefits were noted, especially in the pathologic node-positive and triple-negative subset. We do not know the balance in the two arms for the amount of residual cancer burden, however. Discussion among experts about these as-yet unpublished results and whether or not we should consider commencing such therapy in our practices has been mixed. The type of neoadjuvant chemotherapy used in many of the patients on this trial, sequential A, then T, for example, is not standard in Western populations, and we do know that the metabolism of capecitabine differs in Asians and Caucasians. However, we do need to recall the intriguing subset analyses in the SPIN-XX and U.S. Oncology adjuvant trials, both of which favored the capecitabine arm in the triple-negative subgroups in each of those two trials. You are encouraged to consider enrolling your patients in several ongoing adjuvant trials to address this challenge of residual disease after neoadjuvant therapy. One such trial is the ECOG ACRIN 1131 study, which is addressing the role for a platinum drug or not in residual disease after neoadjuvant therapy for basal-like triple-negative tumors. A second study ongoing is a randomized phase 2 trial addressing combination immunotherapy with the Nuvax vaccine plus trastuzumab in HER2-positive disease. The third ongoing study is the Penelope trial, which is testing the worth of palbociclib or not in combination with aromatase inhibitors in patients with residual ER-positive HER2-negative disease. The second half of my presentation addressed new results in the neoadjuvant setting. First, I provided an update on the I-SPY 2 trial. This is a neoadjuvant consortium trial using adaptive randomization to test novel agents in combination with standard chemotherapy in patients with high-risk tumors as defined by the multi-gene assay MammaPrint plus distinct biological subtyping based on the mechanism of action of the agent in question. Based on the PCR rate differentials, drugs determined to be of interest are then proposed for validation in a signature-defined phase 3 trial with companion biomarker, which the FDA will accept for approval. As of February 3, 2016, the I-SPY 2 trial has registered 1,644 patients, randomized 927, and 822 have completed their surgery. 3 drugs, veliparib, a PARP inhibitor in triple-negative disease, neratinib, a pan-HER inhibitor in HER2-positive and hormone receptor-negative disease, and MK-2206, an AKT inhibitor in HER2-positive and hormone receptor-negative disease, have all been successful in the trial to date. At San Antonio Breast Cancer Symposium 2015, new data were presented for a fourth drug, trebantinib, which is an angiogenesis inhibitor. This agent completed analysis, and the results as presented at San Antonio showed encouraging improvement in PCR rates in several signatures. 1, HER2-positive hormone receptor-negative. 2, hormone receptor-negative. 3, triple-negative. And 4, very high MammaPrint. The agent was extremely well tolerated. Currently, 6 agents and combinations are ongoing in the I-SPY 2 trial, targeting HER2, IGF-1R, HSP90, PD-1, and PARP. The next neoadjuvant theme at San Antonio revisited the role of platins in triple-negative disease. To review, prior to this meeting, 3 trials reported improved PCR rates in triple-negative disease with the addition of carboplatin. The GEPAR-6 trial, which included bevacizumab, CALGB trial 40603, in part with bevacizumab, and the I-SPY 2 trial with veliparib. The modest change in PCR rates in favor of adding carboplatin, which have been previously reported, may not be enough to demonstrate a statistically significant event-free survival benefit in smaller trials. That is, as FDA modeling has demonstrated, as the amount of difference in PCR rates between 2 therapies decreases, there is less power to detect a significant improvement in event-free survival. Also, improvements in PCR could simply be the result of conversion of low-volume residual disease to PCRs and not ultimately impact on survival. Because we now know that low-volume residual disease, so-called residual cancer burden 1, is known to have the same outcome as PCR or residual cancer burden 0. So at San Antonio, both the GEPAR-6 and CALGB 40603 randomized phase 2 trials reported event-free survival outcomes for the first time. These were presented by Dr. Sikoff and von Minkwitz, respectively, for the CALGB and GEPAR-6 trials. I call your attention to an elegant discussion of these 2 abstracts on the San Antonio website by Dr. Angela D. Michelle. In sum, both trials showed a modest improvement in event-free survival in the carboplatin-containing arms, just as predicted by the FDA models for the very modest degree of improvement in PCR rates. This event-free survival benefit was significant in the GEPAR-6 trial, but not significant in the CALGB study. So, should a platin be a part of standard therapy for neoadjuvant or adjuvant triple-negative breast cancer? I share the opinion of the San Antonio discussant, Dr. D. Michelle, and that is not quite yet. One might consider it if you desire rapid local control for locally advanced disease and possibly in BRCA-positive cancers, which is still under investigation. But outside a clinical trial, there is no proven role to add platins for an overall survival benefit post-neoadjuvant or in the adjuvant setting. And should one choose to use it on a case-by-case basis, one must also factor in added toxicity reported in all these trials from the addition of carboplatin. Next, I discussed an important first report of a neoadjuvant study for triple-positive disease presented by Dr. Nadia Harbeck and colleagues for the West German Study Group. This is the ADAPT trial results reporting the PCR endpoint. It was a randomized phase 2 trial of trastuzumab plus endocrine therapy alone, so no chemotherapy, versus TDM1 plus endocrine therapy versus TDM1 alone. The invasive PCR rates for both TDM1 arms were 41%, significantly better than the 15% invasive PCR rate for trastuzumab plus endocrine therapy alone. Thus, avoiding chemotherapy in triple-positive breast cancer appears to be insufficient therapy, at least so far based on PCR rates. Finally, I reviewed the provocative combined pre-surgical window neoadjuvant trial of Dr. Cynthia Ma and colleagues. Anastrozole was started with pre- and post-biopsies, and palbociclib was added. The primary endpoint was complete cell cycle arrest by Ki-67. This complete cell cycle arrest rate exceeded the study objective of 66% for the combination, which was significantly greater than anastrozole alone. Thus, this promising combination should be studied in the adjuvant setting. Our 6th faculty member was Dr. Lajos Pusztai, who reviewed prognostic and predictive biomarkers for precision breast cancer therapy. I will start with the 4 major questions he posed with his take-home points for each question, and then circle back to review a few of the key abstracts he discussed to support his conclusions. So his first question was, can germline BRCA mutation results be used as a chemotherapy response predictor? His take-home point is there is a mounting evidence that BRCA mutant cancers have above-average sensitivity to platinum drugs and maybe to anthracyclines, but not to taxanes. The second question he considered was predicting short and long-term risk of recurrence for ER-positive breast cancer. Are we there yet, especially for late recurrence prediction? His take-home points were that several independent studies demonstrated proof of principle, and several commercial assays are also available. But whether use of these assays improve patient outcome is yet to be determined, except perhaps for the 21-gene recurrence score assay, data which I also reviewed in my presentation. The third question he posed was, are tumor-infiltrating lymphocytes, or TILs, ready for prime time as prognostic markers? His take-home point, TILs have proven independent prognostic value in triple-negative breast cancer, but are less useful in ER-positive breast cancer. And his fourth question was, what new insights might we glean from whole exome sequencing? And he concluded there are large individual differences in molecular defects, but there is phenotypic convergence. I will now circle back and outline for you several of the most interesting abstracts that Dr. Pushtai reviewed. Regarding chemotherapy response and BRCA mutation status, he discussed recent literature in the Gephardt-Quinto trial reported at San Antonio to support his conclusion that anthracycline and platinum-based regimens may be more efficacious in patients with BRCA1 or 2 mutations. These patients had significantly higher PCR rates after neoadjuvant EC followed by docetaxel chemotherapy, which was further increased by the addition of bevacizumab. Patients who had BRCA1 or 2 mutations had a slightly better prognosis in this study with a hazard ratio of 0.64, p of 0.06. Dr. Pushtai cautions that more data are needed before a change in practice standard should occur in patients with BRCA mutations. Dr. Pushtai's second topic addressed new results for 2 molecular assays for prognosis and prediction that were presented in the oral sessions at San Antonio. EndoPredict by Dr. Dowsett et al., and the next-generation sequencing analysis of SWOG 8814 that I presented on behalf of my colleagues. The EndoPredict analysis of Dowsett et al. Was done on the ATAC trial, and an EndoPredict clinical tool was also studied which combined clinical and anatomic variables and molecular features to predict late relapse. This was also compared to the Oncotype recurrence score, but not to the recurrence score plus clinical tool that is also available. In sum, for node-negative disease, Dr. Pushtai reviewed that both EndoPredict clinical and the recurrence score alone do risk stratify patients similarly. Low recurrence risk patients have a 5 to 6% risk of relapse with endocrine therapy alone at 10 years. He stated this is not surprising since the prognostic value of tumor size alone within the 1 to 3 centimeter range in ER-positive cancers is very modest, so that in reality, EndoPredict clinical is just like EndoPredict alone in this particular analysis of Dr. Dowsett and colleagues. In contrast, the addition of clinical variables improved risk stratification in node-positive cohorts over EndoPredict alone, as well as compared with the recurrence score alone. However, there was no direct comparison with the recurrence score plus clinical tool that is available. Dr. Pushtai cautioned that while this is an intriguing analysis, the results are not yet validated prospectively to determine who would most benefit from prolonged endocrine therapy. Specifically, we do not know if the patients with late relapse predicted by these tools would have these events eradicated before they become clinically evident if they were given longer duration of therapy or some other strategy to deal with other mechanisms of resistance. The SWOG 8814 next-generation sequencing whole transcriptome project that I presented earlier for prognosis in the adjuvant setting in node-positive ER-positive disease was also addressed in detail by Dr. Pushtai. In addition to the results that I highlighted, Dr. Pushtai emphasized our findings that many individual genes were prognostic for early versus many fewer for later events. The low ESR1 metagene was significantly associated only with early recurrence, whereas the high proliferation metagene was significantly associated with both early and late events. Even fewer individual genes predicted benefit to CAF chemotherapy added to tamoxifen. A much better predictor was a 3-metagene model that included ESR1, TGF-beta, and proliferation genes, which provided excellent discrimination between who with positive nodes could avoid chemotherapy and receive endocrine therapy alone versus those who need both chemotherapy and endocrine therapy. The SWOG group plans to validate these results in the responder trial, SWOG S1007, which recently met its accrual goals. The third topic Dr. Pushtai considered was the increasingly complex area of tumor-infiltrating lymphocytes, or TILs, and their prognostic and predictive roles. And he discussed the different findings vis-a-vis stromal versus tumor TILs. He reviewed the oral presentations of Dr. Desmet et al. Regarding TILs in invasive lobular cancer and the meta-analysis presented by Dr. Lowe and colleagues. Dr. Pushtai opined that while TILs have proven independent prognostic value in early breast cancer, how this information could benefit patients with triple-negative disease or lobular cancers is yet to be determined. Dr. Pushtai concluded by reviewing the work of his own group presented at San Antonio on whole exome sequencing of pre-treatment biopsies from the NEO-ALTO trial. The objective was to identify DNA aberrations associated with response to the 3 HER2-targeted therapies in the trial, that is, trastuzumab alone, lapatinib alone, or the combination of both. At the single gene level, only PIK3CA mutations showed significant and negative association with pathologic complete responses. However, the combined mutation status of the PIK3CA network of genes plus the RHO-A gene pathway appeared to define patients with a very low response rate to trastuzumab alone that can be augmented by either adding lapatinib or substituting trastuzumab with lapatinib. Our last speaker was Dr. Harold Hal Burstein, who was charged with providing his take on the entire San Antonio Breast Cancer Symposium 2015 meeting in terms of its impact on breast cancer practice and research. Dr. Burstein first addressed the abstracts pertaining to adding HER2-based therapy in small HER2-positive tumors and to avoiding chemotherapy in higher clinical risk but low recurrence score tumors. He stated that, quote, cases that don't need more treatment, close quote. That the good outcomes likely extend beyond those narrowly defined groups, and he noted that the research questions for new agents are all in high-risk groups, whereas the research questions for low-risk groups involve quality and consistency of care and doing less without compromise in outcome. He then addressed the PCR event-free survival controversy, which I recently reviewed for you, the role of neoadjuvant platinum, and other aspects of neoadjuvant therapy reviewed earlier in our meeting. He concluded that carboplatin adds to PCR in triple-negative breast cancer, but perhaps the greatest benefit was observed in the GEPAR-6 trial, which avoided an alkylator, as alkylators also work for triple-negative breast cancer. Thus, it is unclear if carboplatin adds to event-free survival or overall survival, in addition to the AC followed by T regimen, which contains an alkylator. He agreed with other faculty that BRCA-associated tumors are more likely to have a PCR, but that this seems to be the case with any chemotherapy, including platinums. Dr. Burstein suggested we may have set the bar too low with respect to changes in PCR in our trials, and that the group that deserves more focus is the one with residual cancer after neoadjuvant therapy. He suggested that in select patients who have a large residual disease burden, additional therapy with capecitabine can be considered outside a clinical trial. Regarding immunotherapy for advanced breast cancer, Dr. Burstein indicated progress in breast cancer is lagging behind other tumor types, and we should not, quote, reinvent the wheel, close quote. Therapeutic principles to be explored include the role or not of PD-1, PD-L1 testing, combinations of CTLA-4, PD-1, PD-L1 targeting, and combinations of chemotherapy and immunological therapy, all well underway in other types of cancers. In addition to the Keynote trial already discussed earlier by Dr. Ellis, Dr. Burstein indicated the Phase 2 trial in triple-negative breast cancer presented at San Antonio by Dr. Adams and colleagues of atezolizumab plus nab-paclitaxel was encouraging. Dr. Burstein concluded by selecting the studies reviewed by other faculty of translational research of high import, including ESR1 mutations, HER2 mutations, especially a study in which neratinib may be particularly effective, and the use of circulating tumor DNA technology in predicting response to targeted therapies. Dr. Burstein predicts that these key translational research findings will soon find their way to our daily practice, and I agree with him 100%.
Well, I hope you've enjoyed this quick walk through the highlights of the San Antonio Breast Cancer Symposium from the perspective of experts in the field. While this year's San Antonio did not have what you would call a breakthrough presentation, on the other hand, it had an extremely large number of very exciting papers that fueled debate in the hallways and further discussions after the meeting was over. So I'm sure you have many questions that have come to mind as you've been listening to this. Feel free to go to the San Antonio Breast Cancer Symposium website and watch the individual presentations, which can be done by anyone. And we hope to see you next year at the 14th annual The Best of San Antonio Breast Cancer Bench to Bedside.